So our next speaker, renowned speaker, Dr. Amar Lal, give me the opportunity give me great pleasure to present my colleague and friend, Dr. Amar Lal. Dr. Amar Lal graduated from Dow University in Pakistan. He completed his residency and then fellowship in medicine and oncology. So he's double qualified in medicine and oncology from Pakistan. He also got a triple diploma from United Kingdom, from the Royal College of Physicians in Ireland, and also the Royal College of Physicians of Glasgow in medicine, and also qualification in diploma in oncology from the Royal College of Physicians in London, and also he's board certified from ESMO board in oncology. Dr. Lal has been a local and international speaker. He's an excellent speaker, and he have got over 20 publications. He is now a senior hematologist in Dawam Hospital here in Al Ain. Dr. Lal talk will focus on a case discussion, and I hope for ITP patients. So Dr. Lal, the floor is yours.
Yeah. So thank you very much, Dr. Hani. It's a nice introduction. And thank you for inviting me to talk on ITP, A New Hope. So what is the new hope? Actually, you have listened, Professor Philip, that the steroid has a bunch of all the side effects. And there is also the problem when to, discontinue the medication. This is also issue. So we'll see, Okay, please, next slide. This is my disclaimer, no discuss. Next, please. So in next 20 minutes, I will take you 7 steps, one eye opener, and D8 of just review briefly ITP, and then initiative and goal, then ITP journey, what to remember, A to G, and then advantage of romiplastin and real world experience of my cases. Next, please. So this is just eye opener. What color is the ribbon for ITP? Just keep in mind, check the answer. Yes, please. Purple. Okay. Next, please. So D1 definition, how we define is primary, is based on the primary or secondary. Primary means isolated thrombocytopenia without any known cause. Secondary means either infection, infiltration, means any malignancy. And other definition is by chronicity, as Dr. Philip has mentioned, newly diagnosed up to 3 months, up to 12 months is persistent. Beyond this, we call it a chronic. Next. D2 is demographic. The demography, you can see female and male almost equal, but it is seen higher in the higher age group. Next, please. D3, diagnosis. If you go to the left side of this chart, how we make a diagnosis, basic thing is history, physical, and peripheral phlegm. And the basic test is some hepatitis profile and HIV and H. pylori. Other tests, we don't do it until unless needed, like ANA and some other factors. Next, please. So D4 is diagnostic key. Actually, what is the diagnostic key? Diagnostic key is peripheral phlegm. If there is clumping, you have to collect the blood sample in a heparinized syringe. You have to see whether this is pseudo-thrombocytopenia, real thrombocytopenia. And most important thing is you will see the large platelets, which is especially seen in the ITP. Next. D5 is diagnostic dilemma. What is the dilemma? The problem here, it is some people use, to check platelets autoantibody testing, but ASH guideline doesn't recommend to check for platelets autoantibody. The reason is the sensitivity somewhere fall between 20 to 30%, although it is very specific. So that's why ASH doesn't recommend it. Next. D6 is, you can say, drug journey. Drug journey started after splenectomy, then roids, then IVIG, then now we are going in era of TPO agonists. Next. D7, how to make an initial management. What are the goals? What does the patient require? And should the patient be admitted or not admitted? We'll discuss according to my patient scenario. Yes. D8, Next. So D7 actually, this is also from ASH guideline 2019. Actually, what they recommend that if you see the platelet count, if it is more than 30,000, no need of anything, just observation. If it is less than 30, then you have to start steroids, which can be 6 weeks minimum. You can say maximum 3 months. Usually people prefer 6 weeks to 12 weeks. And if platelets count is less than 20, then you can admit or the patient have any severe bleeding. Otherwise, you can treat as an outpatient. Next, please. So roids are two actually, prednisolone and dexamethasone, as Philip has mentioned, same like, people mostly use prednisolone. So we also use prednisolone based on the data. Next, please. And if some patients who need urgent to stop bleeding and to need to push the platelet count, so there are two things here you can see in both cartoons. If you see in the left side, you can see IVIG. What is the basic mechanism is a very good figure actually I wanted to show you. You can see when you induce IVIG, actually it occupies the FC receptors, and so there is no place for platelets or antibodies. So that's why they save 2 to 3 weeks the patient from destroying the platelets. And if you see in the right side, you can see here again, if the patient have the Rh positives, then you use anti-DNA immunoglobulin, then again, this is the same way, it adheres the FC receptor and there is no place for the platelets coated with antibodies. So they also protect up to 2 to 3 weeks. Next, please. And now, so the idea is hope beyond the steroid. Actually, some data are coming even because Amgen doesn't want to show actually, otherwise on, TPO agonists also coming up front and rituximab will also come up front. But this data is also indicating MMF, which has shown higher response rate and durability if you ate initially as well. Next, please. So you have seen the roids are the preferred initial treatment of ITP. However, both spontaneous and steroid-induced remission are uncommon. It's uncommon means not more than 30%, it's 20 or 30%. So suggestive data that the use of TPO or the component initial therapy may improve, which are not shown here, but it will come in future. However, roids are overused in ITP, as Philip has mentioned, that it should be limited up to 6 week initial therapy and should not be continued. And we have to quickly to switch to second line as well. Next, please. So what is second line? Second line, you have option TPO or a rituximab and a fostamatinib. It's up to your choice, patient's condition, preference, lifestyle, risk of bleeding. You have to discuss with the patient. Next, please. So TPO agonist, which is the second line, preferably because it's 50 to 90% response rate, actually is very quick response within 1 to 2 weeks, and sustained response up to 20 to 30%. Even you discontinue the treatment. That's why it's awesome. And now new data is emerging. Even the new third generation TPO like Eva or Tromobag is also coming pre-surgical. If you push it, and within 1 week, patient will be ready for surgical care. So somehow, as you have seen, the TPO or as the safest, and we have now 3 TPO, and we'll discuss later which is the best one. Thank you. Next slide. So for second line, so how to treat ITP? So you have seen many ITP patients don't need treatment if it is more than 30,000. And if you need urgent treatment, you can use IVIG and steroid. Otherwise, the steroid is enough. And we have to avoid to remove the organ. We have now plenty of options, including Rituximab, TPO agonist, and new emerging medications like fostamatinib is coming. And we discuss. Next, please. So, but burning question in 2021 or 2022, which TPO agonist is the best in ITP? Now we have 3 TPO. We have to see which is rapid responser. We have to see which have the durability. We have to see which have long-term efficacy and which we have the sustainable response and duration and discontinuation data. Next, please. So here is the data which show approximate time to response. So you can say almost equivalent sub-Q and oral both have the same response. Next, please. So romiplastin, a newly diagnosed persistent, also shown. This cartoon you can say from first is about 60%, and then second graph is also showing this very effective as well. Next, please. And this is the long-term efficacy, as I mentioned. We have to see the long-term side effect and efficacy. Here is the persistent maintaining the platelet count is more than now 6 years data is over there for romiplastin. Next, please. Romiplastin offer rapid response with remission occurring about 1/3 of patients who have to off therapy. We will see how it happens. Next, please. And you have seen here in this diagram on left side the treatment TFR, and you can see it is about more than 50% as compared to 24% of the oral TPO agonist. Next, please. So now coming, this is my just reminder, or you can say eye opener of the ITP basic review. Now I will go through my 4 cases, real world experience. And in these cases, I have decided it's from A to G. A means accurate diagnosis. B means before beginning the treatment, check there is indication or not indication. C is convenient drug, which is, and D for toxicity, you have to see drug, which is the, and you have to see discontinuation of option. Then E for efficacy and evaluation of the treatment and feasibility and future direction, and guiding the guideline is the G. And the last is hit, means a heading idea for future. Either you hit the disease or you hurt the patient, who will see accordingly. Next, please. So this is my patient 1, 53-year female, who presented typically bruised and in the overall extremities, and she has also history of gingival bleeding on the toothbrush. And the hemoglobin was fine, 12, WBC4 fine, but the platelets was 12. Other chemistry was normal, and previously she has no any comorbid. She's housewife. On examination, as I mentioned above, she has multiple areas of ecchymosis in both extremities. Other examination is unremarkable. Next, please. So now the question is, which of the following is most useful achieving the diagnosis? And you remember, what is the diagnostic key? Here is the diagnostic key. Please, next. Yes, this is the diagnostic key. Check the peripheral film and forget all the other things. Very simple test. Peripheral film, if it is clumping or not clumping, the real platelets, you have to see everything in the very simple test. Next, please. So our diagnosis in this patient, film was checked. It is typical thrombocytopenia, is isolated. All the other markers are negative. And as for ASH guideline, we also checked, some ancillary tests like hepatitis and HIV and H. pylori and that and other things were checked also. Next, please. So now the question is, now it's confirmed, and B, before beginning the treatment, check indication. You think its indication is there? Yes, there is indication. As platelet count is 12 and patient has ecchymosis and gum bleeding. So what is the appropriate next step to address this patient? Next. So these are the 3 options, steroid, IVIG, or combination of steroid, IVIG. So what we did, next, please. So initial treatment is, either the combination and then followed by steroid and the tapering dose, or pyridinone or dexamethasone. It's your choice what you choose. Next. So now E for efficacy, you see in this patient, I start IVIG and steroid because of very low platelets, and patient was bleeding as well. So she responded very well. You can see the graph is going up. And what happened, but after a few weeks, actually, the graph went down. So next, please. So this is also same graph. It's actually went down, dropped to again 10,000 platelets. So by definition, now it is what we should label this patient: relapse or refractory. Next, please. Next. Yes, it is. elapsed ITP. Why? Because it responded, it was not failure, it responded initially, then it lost the response. So I would label this patient as elapsed ITP. We label refractory when the patient has no response over the 3 month and platelet count is less than 15. This patient you have seen, she responded very well. It went up to 150,000, but it again dropped. Next, please. So how should this patient be treated? Again now, please, next. So these are the three options everybody knows: surgical versus medicine. So either you have to take out the organ or you can give rituximab or TPO agonist. Next, please. So these are the guidelines, all options are available. So this is the confusion of the drug decision. It's up to you, and you can discuss with the patient pros and cons. So let's see next. But here is confusion is over by the recent ASH guideline, and you can see it's very nicely, if you go to the left side, which is orange color, which is they are showing if it is up to 12 months, you have only two choices. Either you give TPO or rituximab, and if it is more than 12 months, then we have three choices of parameter. If you go by one, we will discuss accordingly. Next, please. Yes. So in this patient, actually, he chose, we discussed the patient, she chose, actually, she wanted to continuation of the therapy. So if for the continuation of therapy, you have two choices, either rituximab or the TPO. So if you go other side, left side, you can discuss with them for indefinite treatment or is their choice. So next, please. So in this patient, actually, TPO agonist romiplastin was given. And next, please. Next. So this is now romiplastin response. So she continued romiplastin over the year, and then you need there to discontinue because, as Dr. Phillips has mentioned, you don't have enjoy the platelet count more than 3,000, 4,000. Just think smartly if you can dare to decrease the dose. But that we do wild best practice in the romiplastin. So the dose is like weekly base. You can say for 4 times a week. What we usually do, we do discontinuation. We make it 3 times a month, like every 10 days. Then, gradually 2 times a month. We see, up to 3 months, if patient is doing great, then we off the therapy. So in this patient, you have seen this is the graph, and the patient had durable platelet response after the discontinuation therapy. This is the 7-year journey of the patient. So I would say I hit the disease, but I didn't hurt the patient as far A to G of my protocol. Thank you. Next, please. So this is durable platelet response. Yes, next, please. So now I will go to second case. This is 22-year male who has 4-year history of ITP, who was initially treated with a steroid and response. And in second time, he was high dose dexamethasone, then followed by rituximab. But you can see the graph is going down, 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 down. And the patient also have the issue as well. What to do? Maybe some patient cannot afford insurance issue and other things like TPO agonist. So we can see in this patient what happened. Next, please. So in this chart, you can say, if you go the blue one, now more than 1 year. So we have choices of the patient. We give like 3, like ASH treatment. Now it's very clear what the patient want. They wanted to continue therapy. They wanted to go, like for indefinite treatment, like rituximab and splectomy. So it was discussed with the patient. Patient wanted to take out spleen out because he cannot continue the treatment. So because rituximab is already given. So what we should do? Next, please. Yes, you can see here the graph. Initially, surgeons didn't accept the patient, so we gave romiplastin 2 doses. The platelets went up. Actually, it was good response, but patient didn't want to continue the treatment, so his spleen was taken out. And you can see this is durable response. It went jump. This is typical of after splenectomy, and he's now off any therapy. So now it's the more than 7 to 8 years journey of this patient. So I would say I hit the disease, but not hurt the patient. Maybe hurt the patient, we take out the spleen. Next. So this is durable platelet response. Next, please. So this is case 3, young lady, 27 year, and she is she is almost every other year. The problem is with the pregnancy, and she has Evans syndrome as well. So she was taking on and off IVIG and steroid. If you see the graph, can you show the next one, please? Yes. Yeah. Here I wanted to show the graph. You can see the first one, the blue one. You see platelets up and down because of you cannot offer her anything except steroid and IVIG because of her. As I mentioned, she was in era of her pregnancy. She has in this period 3 times she became pregnant because of this reason. So after next, please. So what happened? This is again interesting. The patient in 2013, she came in the ER with left leg swelling. Although she was just taper of the steroid, she was doing great. The platelets count was 124, and the Doppler was also negative. The thing is now what we should do: either discharge the patient, repeat ultrasound, or CT venogram. Next, please. So we did CT venogram because the patient was symptomatic, left leg swelling, and she has slightly saturation drop as well. Next, please. So this was, it was then say IVC, and that revealed actually she had ultrasound was negative, but CT has shown large IVC clot there, which is extending to left iliac and femoral vein. So she has also palpitation and tachycardia, as I mentioned. She also underwent CT test as well. So she has small PE as well. Please, next. This is her PE, which is showing in the CT-PE protocol. Next, please. So in this patient, this was admitted and we started actually enoxaparin and the warfarin, followed by warfarin. But again, the problem is her ITP also exaggerated. This was also challenging. Her platelets drop is 10,000. Next, please. So how would you manage this patient? Patient has VT, also decreasing platelets count. So what I did, next, please. So continue anticoagulation, and we just added steroid because we cannot give anything else. Next. And she went very well, and we discussed and we checked everything for her, thrombotic screen, factor V Leiden, lupus, all the things were negative actually. So we planned her, we gave her offer, same thing, which is now ASH 2019 is indicating offer the patient all 3 options depending on the patient prefer. Next, please. So these are the options which I highlight on the red color. So what the patient has mentioned, she had to continue either rituximab or TPO agonist. Next, please. So in this patient, actually, you can see rituximab was given 1 time, but she dropped the platelet count. Then romiplastin was given, and she took 1.5 years of the romiplastin. Then I discontinued as well. She's now off therapy more than now 2.5 years. She's doing well. So this is a 10 years of the journey of ITP. This is my 3rd patient. Next, please. So this is the last case, 4th patient. This is a young guy who was, he's about 35-year male who was diagnosed around, again, 10 years ago. ITP, typical, on peripheral phlegm and all these things, which we discussed before. And he chose initially altromabag that caused a problem. Because he was taking also PPI and other things, that was also interruption. So that's why platelets count was not maintaining. Then we try for rituximab, and that you can see the graph went up, then graph down. Then he took romiplastin, and you can see the graph beautifully. It's maintained. After 2 years, we dare to taper off this patient. Now he's tapered off. Now he's more than 2 years off of the romiplastin. So this is also one of the successful case of sustained remission of the ITP after romiplastin tapering and discontinuation. Next, please. Next. Yes. So in last 20 minutes, in my talk, which was actually given to me to hope for ITP patient, what we have seen, sonar is better. You can aid TP agonist to get the better response, and try to off it to discontinue it. It is very easy to discontinue. So even now we in an era of, you have seen in CML we are going TFR, but this is the more easiest one. It's a very simple way, and you can do this way. So I have gone through the D8 of the ITP. I have to gone through the ITP journey, how to remember A to G hits, and then initiative and goal. Then I have shown the advantage of romiblastin and the real world experience. So this is all. I finished my talk. Thank you very much, and put your question. I will be happy to answer it. Thank you.